Everyone, thanks so much for having me. My name is Jenna Tosto-Mancuso, and I am a physical therapist and the clinical director at the Abilities Research Center here at Mount Sinai. And today I have the pleasure of talking with you a bit about the intersection of technology and rehabilitation. So a quote that always resonates quite nicely when we're thinking about this topic is, we can't solve problems by using the same kind of thinking we used when we created them. So where does innovation come into the space of rehabilitation and problem solving for patient cases that span from quite straightforward all the way through some of the most complex patient cases that we've seen? And so for the purposes of our talk today, we'll primarily be talking about patients after neurological injury in the neuro rehab space. And so again, when we think about that, just take a moment and try to imagine what that patient looks like. Maybe it's a patient who you have seen yourself. Maybe it is a depiction of a patient seen in the media. Perhaps it is a family member or a friend. Individuals after neurological injuries, their residual deficits and the residual barriers that they face are very widespread and oftentimes really pondering and complicated for both the patient, but also those of us in the medical community. And so I ask you, how do you solve those problems? How do you face those deficits or those barriers? If not for the idea of thinking outside the box and using a bit of innovation and creativity to solve those problems. And so for our discussion today, some key points we'll be covering. Number one, technology and rehabilitation, just a general overview. Talking a bit more about the intersection of technology and rehab, especially some more modern approaches, primarily things like remote patient monitoring and gamified rehab. How do we innovate in the technology space in the rehabilitation field? How are we, again, thinking outside the box? And like all good ideas, thinking about what are the barriers that we face for adoption and how can we overcome those barriers? So as I said before, starting to think about that patient population in the neuro rehab space, but admittedly, this can be true of any patient population. How many times after a severe illness for which patients survive, that they are told, I'm sorry, we cannot do anything more for you. This happens all too often, especially when we're thinking about things like residual physical limitations, residual cognitive limitations. Patients in a very traditional model of care are oftentimes thought of as, well, the acute event is over. So I'm sorry, that's it. That's all we can do. This is as good as it's going to get. And so this is one of my favorite pictures. I did have the opportunity to find this picture from a previous presentation given by Dr. David Petrino, in which it really depicts our ability to challenge that and to start to think of our patients and the care that we provide in the rehabilitation space, not just as deficit dependent or impairment based, but rather starting to think of our patients in terms of human performance, in terms of the human body's ability to recover and to change. And, you know, the idea that patients are superheroes and that we can do so much more than say, well, I'm sorry, that's it. So technology really allows us to embrace that ideology and to really start to think about that next level of progression. How can we change the script for our patients and say, no, that's not all you can do. So a few key things that we know and a few key principles that should be taken into consideration when we start thinking about technology and rehabilitation in this space. Number one, neuroplasticity, the brain's ability to change when provided a proper stimulus. And so in the face of neuro rehab, we know things like high intensity, high repetition, task-specific training. All of these things are incredibly important for promoting neuroplasticity, both from a molecular and a cellular level, all the way through a systems level, through an adaptation level, when we start to think about principles of motor control and motor learning. Salience, is it meaningful? Is it personally significant to that person, right? Does this capture really what the essence of their goals are and what they want to get back to? And so for a lot of our folks after neurological injury, so many of the things that we look at the surface level, standing, walking, participation in day-to-day life, right? Thinking about things like our ICF model, which incorporates things like body structure and function. How can we impact those? environment. How can we change the environment for which our patients and our general selves interact? And then participation. How do those two things start to come together and allow us to participate in our life roles, into our day-to-day tasks that are meaningful and salient? Additionally, there is an enormous body of literature that supports how enjoyable something is, right? If you are enjoying what you're doing, especially in the rehab front, you're far more likely to have an impact on that neuroplastic effect. And lastly, when we think about technology, we start to think about objectivity. So much of our work in the rehab space traditionally and historically has been subjective. So it has been really based on observation without quantifiable data-driven markers of progress that really should guide our change. And so when we start incorporating technology into that picture, it allows us to be more granular and to be more objective. So when we start thinking about successful technologies in the rehab space, it really starts to incorporate those three primary principles. And admittedly, these are not the only principles we should be thinking about, but in my opinion, these are the three most important. And so as we take those combination of factors in, we start thinking about how does technology and rehab start to intersect? And so I'd like to take a look through three primary phases of rehabilitation, if you will, that we can start to incorporate technology in. So the first being remote patient monitoring as a pre-habilitation modality. And so for context, remote patient monitoring is a relatively new telehealth, if you will, or mHealth initiative that really took flight during the COVID-19 pandemic, or I should say at the start of the COVID-19 pandemic, in which we are enabled to better understand and to essentially monitor patients over the course of their interaction in the health system. And so when we think about pre-habilitation, it is proactive. It is not reactionary. It is not it is based more on a wellness model as opposed to a model that says this has already happened, we're already in the thick of it, what are we going to do? And so when we think about remote patient monitoring, or I might be referring to it as RPM, as prehabilitation, one of the really great examples of that is prehabilitation for individuals who are going to be undergoing surgery, so preoperative patients. In this case, we are talking about, and as the image depicts, preoperative spinal surgery. So it allows us to get a better baseline of patient function. In the RPM model, we can do things like monitor patient-reported outcomes, things like pain scales, functional limitations, functional mobility status. Further, we can look at things like strength, range of motion, motor control prior to an individual surgery. And so the beauty of that is we get this very strong baseline that post-operatively we can compare to. And there's your objectivity, right? There's your ability to track how a patient was doing beforehand and then start to see the outcomes of the intervention in real time. Further, the really great thing with RPM is that it allows us to have a much more granular view of patient recovery. And that can be said for both prehabilitation, rehabilitation, and the acute phases of care, rehabilitation, and the chronic phases of care. Generally, when we think about the standard healthcare model, our patients are extremely limited in access they have to providers. So an individual may see, let's take this case of a patient undergoing spinal surgery. They may see their provider or their surgeon preoperatively a handful of times, and then they'll see them a handful of times postoperatively, but by handful, we usually mean immediately after the surgery, several weeks after the surgery, several months after the surgery. There's that lack of consistent monitoring, that lack of consistent data flow that really could optimize our outcomes. And so when we think about the big picture of technology, this capacity for RPM, remotely monitoring patients, whether that is through, and right now those RPM billing codes, which we'll get into a little bit later, it requires the use of a Bluetooth enabled device. So now you're getting physiological data. you're able to capture metrics of patient recovery that are coming in day by day by day. So it's that really that one-to-one interaction with the health system that provides granular data. So in the event a clinical red flag is identified, say in this prehabilitation model, patient is demonstrating worsening status or worsening symptoms, it can be picked up on so much more quickly as opposed to our traditional model of care, which requires the patient to, handle things on their own. Perhaps they're not escalating red flags because they're not identifying them or they're unaware of them. In the case of remote patient monitoring, again, in which that data can be directly communicated back and forth from the patient to the health system, we really have a much better idea as to how our patients are doing across the continuum of care. And so when we think about, again, this continuum, we talked prehabilitation. So prior to something happening, being a little bit more proactive, we can also use the example of remote patient monitoring in acute disease. And in my humble opinion, the use of remote patient monitoring at the start and then throughout the COVID-19 pandemic is exemplary. And so just for context, here at Mount Sinai, we have a remote patient monitoring program called Precision Recovery, which I happen to be the clinical director of, in which we had taken this model for RPM that was previously developed for patients with neurological injuries, which I'll talk about in a bit, and really, really quickly pivoted to design a program that allowed us to track the day-by-day status of individuals who are acutely diagnosed with COVID-19. And so what that entailed was patients using a phone-based application, as well as a pulse oximeter and a blood pressure cuff to capture physiological metrics of their health status. And so every day, patients were reporting on their symptoms, reporting on their oxygen saturation, reporting on blood pressure, reporting on fever, really in the face of a diagnosis that was so incredibly unknown and admittedly so incredibly scary. So you have this entry of data and this exchange of remote data exchanged back to individuals on the healthcare system front. So as that data was coming in, teams of clinicians are monitoring the information, and it gives real-time access to identify clinical red flags. And so in this cohort, we were able to, number one, triage patients as needed if someone was demonstrating a change in clinical status. The goal was always to identify those deteriorations prior to them starting. And so we were able to really capture patients who potentially would have waited to be seen at the emergency room or who would not have gotten care as quickly, largely just because of the saturation of the health system at that point in time. We were able to monitor them so closely that should a clinical red flag be identified, that triage and that escalation of care happened almost instantly. And so for that, that is just a beautiful demonstration of remote patient monitoring and technology in acute patient care. Further, it helps in the face of healthcare utilization on the contrary train of thought. So as we all remember, in those first several weeks, several months of COVID, and then admittedly still to this day, the symptoms were not very well understood. We did not understand the disease progression, especially in that acute phase. And so we had this vast saturation of the health system, vast utilization of the health system that was overwhelming. And so with remote patient monitoring, we created that safety net. So for patients who were acutely ill, but were not in need of immediate medical attention, who were stable to remain at home, those patients were able to have this safety net of RPM, knowing that they had a medium for reporting their symptoms and that they were being monitored. And again, this changes the entire landscape of patient care, and the fact that without RPM, these are patients who would have perhaps been seen at urgent care, would have perhaps come to the emergency department and then been discharged, but still that's the utilization, and really would have been out in the health system when perhaps their need was not immediately there and they could have been managed safely at home. So this is just a really terrific example of how technology helps in those acute phases of disease management. And then lastly, as we spoke about this use of RPM from acute to chronic transitions. And so this is really talking exclusively on our patients with chronic diagnoses. And so we know that there's a phenomenal body of literature coming out in the use of RPM in things like cardiac management. Much of the seminal literature in the RPM space is in the cardiac population, but we really are seeing the utilization for RPM and the case for RPM if we take something like neurological rehabilitation. And so we take the case example of a patient status post-stroke. Patient presents to the emergency department. They are treated in the acute phases for that stroke. And then as they become more medically stable, they are discharged home in most cases, following perhaps a rehabilitation stay, depending on need. But these are the patients that are sent home and said, okay, sorry, that's all we can do, right? Go back to that original thought process. And the beauty of RPM in this space is, number one, we're able to follow patients with chronic diseases more closely to identify changes in status rapidly. So one of the leading causes of stroke in this country is uncontrolled blood pressure. For a patient who has a previous stroke, the highest risk for a secondary event is uncontrolled blood pressure. So RPM allows us to track metrics like blood pressure extremely closely to ensure things like stable blood pressure, that patients are compliant with medication recommendations that are keeping their blood pressure controlled. Changes in physical status, which can often indicate new onset or worsening lesions. Any types of change in status that can be, again, more concretely, more granularly, and most importantly, more immediately identified, ultimately will improve patient outcomes. And so RPM in this space is incredibly helpful. Here at Mount Sinai, we do have an RPM program based out of the Abilities Research Center, in which we do exactly this, where we use a phone-based application to track blood pressure, heart rate, oxygen saturation for individuals post-stroke. Further, we track their motor performance. So we do a facial analysis using some of our facial analysis and eye tracking software to detect things like, as that picture in the center here demonstrates, perhaps a change or worsening in facial droop, which is a really great indicator for onset of stroke or worsening lesion. We do a motor assessment in which we look at movement of arms and legs and standing and walking using some great kinematic analysis technology on the back end that, again, is more granular. It lets us be objective. It lets us understand how this patient is progressing, and really making sure that should a change in status be identified, that these patients have access to triage in the health system far more immediately than traditional models of care may suggest. And so this is really, if you're noticing an underlying theme with my talk here today, it's largely that RPM and technology, and we'll talk a little bit more about technology, really optimizes care for patients who traditionally would just not be seen in the health system. It changes that script of reaction or being reactionary medicine, being proactive, and to being about wellness. And I think that is so incredibly pivotal as we continue to move forward in the healthcare space. And truthfully, I think that is one of the most significant roles of technology as we think about future developments and future innovation in this space. And so when we continue to think about other technologies that allow us this capacity for innovation and in rehabilitation specifically, one of the really great areas that just continues to grow and develop is gamified neurorehab. And so I included this in my talk today because the beauty of gamified neurorehab, especially when it is technology enabled, and that this picture demonstrates and what we'll be discussing, is that it allows us to follow along the same lines of that RPM model, in that we are getting more real-time assessment of patient performance, we're getting more real-time assessment of patient progress, and we're taking healthcare out of the four walls of the healthcare space, and we're really embracing telehealth and remote care of patients. So this is an image demonstrating use of a piece of technology called the Mind Motion Go. It's developed by a company called MindMaze. And as you can see watching here, if you see that black box in the left-hand corner of of the TV stand there in the photo, that is a motion capture camera. And the patient here is performing rehabilitation exercises, traditional rehab exercises, things like active range of motion of their arm, while interacting with a gamified medium. So it's essentially taking that exercise and making it a game. So now if we go back to those preliminary slides I showed in the beginning, we're hitting on neuroplasticity. So we're getting high intensity, high repetition, task specific training. The patient is getting hundreds, if not thousands of repetitions per session of a movement, whereas the traditional therapy model, the literature suggests they're getting under 50 movements per session with a therapist in person. So this technology enables those neuroplastic components that really drive neuroplasticity. Further, we're getting salience. Gamified rehab has been shown to be enjoyable, has been shown to be fun for patients. And so now they are motivated to participate in this gaming experience while still addressing those cornerstones of their rehabilitation needs. And lastly, when we think about objectivity, the beauty of using technology in this space is that we are able to get feedback on degrees of range of motion, concrete counts of numbers of repetition, feedback on compensation. And what I mean by that is for folks who are, say, working on upper extremity movement, but they have some weakness, really able to tell us, well, they're weak in their arms, so they're perhaps using their trunk a bit more to get the movement done. And that allows therapists and providers alike to more concretely and more accurately adjust their plans of care to make sure that patients are getting that recovery, that rehab care they need. Further, the beauty of gamified rehab, and especially if we think about the RPM/telehealth space, for that patient who was told, I'm sorry, there's nothing else that we can do, these mediums allow care to be continued far beyond those acute or subacute phases. And I think the sooner we as a healthcare community acknowledge that many episodes of care, many injuries and illnesses that maybe on the surface appear to be an acute event are in fact chronic diseases that need to be managed. And I think stroke is one of them. To say that once the actual insult or injury has been stabilized, that a patient who sustained a stroke has quote unquote recovered, I don't think gives enough credence to the road to recovery from a physical and a cognitive perspective. And so things like remote patient monitoring and telehealth and technology specifically, they really enable us to do so much more for our patients and to really continue the road to recovery longitudinally into those chronic phases. And so as we talk about things that are exciting and innovative and really getting us to think about rehabilitation and the needs of individuals, there will always be barriers. And so this is just a depiction of the quote unquote valley of death, which essentially suggests that the time to translation from bench to bedside is anywhere from 14 to 17 years, which, yes, years, is remarkable. And there are so many barriers to adoption that I think need to be acknowledged and to be considered when we're starting to think about tech-enabled rehabilitation and technology in this space. And so everything from utilization, adoption, clinical buy-in, resources, meaningfulness and salience, really getting that technology idea from idea to innovation needs to be considered, because that's really the quote unquote valley of death is so frequently where great ideas just, they go to die and they don't get pushed forward. And I think that as we think about innovation in this space, it's something that needs to be considered in order to make our technology successful. And so with that, I leave you here. I look forward to answering questions and talking about the topic further. It's something that we're incredibly passionate about. And I hope this got you thinking again about technology in the rehabilitation space. So thank you for your time.